Awesome. Well, hi, everybody. Thank you for being here with us today, and welcome to our session entitled The One Big Beautiful Disruption, How OBBBA Will Reshape Mental Health Care. I'm so excited for this discussion, and also just really pleased at all the interest that we had in this discussion. We had over 600 people register for it. So hopefully many of those will be on here live with us, but if not, we're also going to send out the recording after so that you can reference some of the stuff that was talked about today. But I think the fact that we had such interest in this topic really points to the fact that many of us are very confused, don't understand it, really want more clarity on what this bill means for mental health and for the overall healthcare system, for workforce, for all of the above. So those are the topics that we're going to be talking about today. I'm so happy to have Stephanie and Anna and Toniann, people who know a lot about this topic. I don't know anything about this topic, so I'm going to play the role of asking a whole bunch of questions. I'm sure you have questions as well, and you are more than welcome to put them in the chat. You can put them in the Q&A. If you want to use the chat to tell us where you're calling in from, please go ahead and do so. But we'll be monitoring the chat and making sure that we pull out some of the questions that we can answer live here today. So I'm going to get into the introductions for each of our panelists, but let me just kind of set the stage a little bit for us. OBBBA is, it's arguably really one of the most significant federal legislations that impacts Medicaid and the mental health service in the last decade. It's a big bill. It has a lot of detail to it. It both restricts and expands, so tightens eligibility for some, while also unlocking about $50 billion for rural transformation and new care models. So there is limitations to it, and there's opportunity to it as well. And we try to be really diverse in our panel today in terms of the background and experiences and perspectives. We have Stephanie, who kind of comes with the payer strategy leader lens. We have Anna, who's a digital health innovator and founder of a startup, and then a rural health champion, Toniann, who, like me, lived in rural areas her entire life and really brings that perspective. So like I said, I'm going to ask a ton of questions, and I'm going to try to keep them as most basic as possible so that we can really understand this very complex bill, that we kind of have the takeaways of, like, what do we need to know? How should we be thinking about things? What questions do we have? All of that sort of stuff. So let me just have the panelists go ahead and introduce themselves. Toniann, would love to hear about you first. Just share a little bit about your background and experience and where you're calling in from.
Sure. Hi, Toniann Richard. I'm the CEO of HCC Network. We're a federally qualified health center serving West Central Missouri, just right out of the Kansas City metropolitan area. I also serve on the board of trustees for the National Rural Health Association, which is how I really got connected to Rachel and this team through our AHEC leader, Stephanie Taylor. So just happy to be here today. And I will say that for the panels that I've sat on regarding OB3 or OBBBA, depending upon the acronym that we're using, I learned just as much from everybody in the audience and on the panel as presenting. And I do feel like this information is evolving and changing every day. So just looking forward to the dialogue, the questions, and then looking for some solutions as we move forward.
Love that. So happy to have you here. How about you, Stephanie?
Hi, good afternoon from Ohio. Anyways, it might still be morning where you're at. My name is Stephanie Stitt. I'm the Director of Behavioral Health and Workforce Development at Caresource. Caresource is the largest Medicaid plan in the state of Ohio, as well as I think we're in about 14 states now. We serve and support 55% of the Medicaid lives in Ohio. And so this topic, is something that we are heavily engaged in and wanting to ensure those who need support are able to receive that support. I'm also a social worker by trade and have very much enjoyed working with the Motivo team.
Love that. Anna, how about you?
Hi, everybody. Thanks for having me today. Great to see you all. And like Rachel, I'm so excited that so many folks are joining us today to have this conversation and that we're getting to have this conversation with such wonderful panelists. I'm Anna Lindow. I'm the co-founder of Brave Health. We are a national virtual community behavioral health platform. We both deliver care and we also do engagement work to help folks get better and different results in participating in their care. So we work closely with managed care organizations as well as with other providers in the regions that we're in. And so we are excited to hear what questions you all may have too, and excited for this conversation.
Awesome. Thank you all three for being here. And I know that chat was disabled in the beginning, but it's enabled now. So if you want to put in where you're calling in from or introduce yourself, please feel free to do so. You can put questions in there. They might get a little buried. You might want to put them in the Q&A instead. That'll be a little bit more of a direct route. But I always love to see the kind of panel that happens in the chat as well. It's like two conversations oftentimes. Let me just quickly introduce myself and introduce Motivo, and then we'll dive into the discussion. I'm Rachel Ledbetter. I'm the CEO and co-founder of Motivo. I'm also a licensed marriage and family therapist. Motivo solves the clinical supervision problem. So we help hospitals, treatment centers, community mental health centers, group practices, and digital health startups as well, all access great quality clinical supervisors if they don't have enough in their internal team and need some additional support there. And as I was thinking about that this morning, I was thinking, wow, Motivo was born out of a regulatory barrier and then a regulatory opportunity, right? So the reason I started Motivo is from a rural area of Georgia. Their clinical supervision when I was going through my license had to be face-to-face. It had to be in person. There were no clinical supervisors in my area. And so I was driving back and forth to Atlanta 2 hours each week in order to get to the closest clinical supervisor. And so that regulation that you weren't allowed to see your supervisor virtually was a huge limitation for me and could have kept me from getting licensed. And to be honest, I think it does keep a lot of people from getting licensed, those barriers around clinical supervision historically. And then that changed in 2015. Georgia changed their rule to allow supervision virtually. The pandemic pushed even more states to beginning to allow virtual supervision. So I just wanted to mention that as a example of the power of regulatory changes, right? It both creates barriers for us, and we'll talk about that some today, how this restricts care for some people, restricts eligibility for some people, and then it also expands by providing some additional, pathways for care as well. So let's dive in. Anna, I'm going to ask you the first question. What part of OBBBA, in your opinion, will have the biggest impact on the mental health system? What do you want to share there?
Yeah, well, I mean, I can speak from our perspective and kind of what we're already preparing for. Whenever there is a significant change, and like you were saying, Rachel, this is a significant one. And in some ways it's unique, but in other ways, this is a continuation of a series of significant changes we have all had over the past, you can call it 20 years, you can call it 5 to 10 years, even if we just look back from the beginning of when the pandemic happened and we all were reevaluating delivery models at the same time with no roadmap together, right? That can be scary, of course, but also an opportunity for new conversations. And so when legislation comes out, we don't know exactly how it's going to look in practice. We know what the law says, but we don't know what that's going to mean as it is promulgated, as the ways that the regulations manifest themselves ultimately are worked out. And that's a process and a journey that is part of our American system and something that will all be going on. For us as providers, right, because Brave at our core, we're a provider, and I think we have a lot of providers on the call today as well. And payers are a critical part of this conversation too. To me, how we're thinking about this today is this is the time to start a conversation. It's almost like if you had warning that there was a moment of shift coming, what would you do? You would talk to the other people who are thinking about the same problems, and you would say, what's the best way to get the best results, knowing that changes could be coming? We don't have all the answers. There's going to be things we're going to find out along the way. But today, we know we do this really well. We know you do that really well. We know we all want the best results. What are the things we can proactively think about together that we may not have before? Maybe it didn't make sense for us to have that conversation before. The same way people might have thought, and just like you were saying about Motivo, Rachel, virtual care's delivery is important. Virtual supervision is important, but it doesn't mean there's a catalyst to do it, right? So the framing I like to use is, what is the catalyst for a conversation we haven't had before? And for us, that preparation means approaching organizations maybe we haven't talked to before. We at Brave do a lot of rural healthcare rural care delivery for individuals living in rural areas, probably like 20% of our patient population. And even just through this panel, I'm saying, Toniann, we need to talk. I need to learn from you about how we can offer the best services to the folks that are in your constituency. What are your organization? How was your organization thinking about this? And so for us, again, really the start of a conversation as opposed to a period being put on a new sentence.
I love that. Yeah, it's definitely an opportunity to spark innovation. And we always see that when something big shifts in or outside of healthcare, that it's an opportunity to rethink and for innovation. Stephanie, what would you add to that? What do you feel like is the biggest impact OBBBA is going to have on the mental health system?
Yeah, we have, so from a payer lens, we're always, most focused on people that need help, and we want to ensure that they have access to those services. And so when we're looking at the Medicaid expansion lives in Ohio, that's just shy of 800,000 individuals that are going to have some new requirements and potentially not be eligible. Within that population, a majority have a behavioral health diagnosis and are currently seeking behavioral health services. This population, when you kind of look at the spectrum, they are just on the brink of being able to kind of exit needing Medicaid. They're likely in recovery or stable in services. They're finding employment, full-time, and on the brink of full-time employment where they can get private insurance, which is what we want. We are highly passionate about. We want folks to get off of Medicaid if that is possible for them. And so this potential disruption, we aren't quite sure what that's going to look like. The other piece of it is the enrollment frequency and the administrative requirements that will come along with it. We are already preparing and ensuring that the members are aware of the increased frequency, checking their mail, needing to send in documentations, things like that.
Thank you for that. Toniann, over to you. Particularly as you're thinking about rural providers, what does this change for you all?
So this is going to sound like Anna and Stephanie and I shared notes before this, which we did not, but I will echo everything that's been said, but to dig a little deeper into the collaboration piece that Anna mentioned, I think the time is right for us to find those community-based partners, private practice, other safety net organizations, in the social space to say, hey, what are you doing really well? And what are you doing really well? Instead of, 5 or 6 people trying to do everything halfway. Now it's time to really leverage those relationships, partnerships, and find those content area experts to say, how can we work together? How can you teach me more about what you do? And how can I send people your way? And the next step of that is to take those plans and those ideas and those innovations to our state and local and federal agencies. Right now, the big push on the rural side is the $50 billion rural transformation project. States have until the end of the year to submit a plan. It's clunky at best as it's written. Every different rural provider I've spoken to interprets it a little bit differently. And if we end up sending 50 different plans to each state for them to dissect, we're going to hit additional road bumps. And so finding ways to bring the right people to the table to present those plans on a united front that really says, hey, what's best for the patient? What's best for the people? What's best for our community? Nobody's going to get, wealthy and rich on this plan. And not that that's the end all be all for things, but we still want to make sure that people are sustainable. And so finding those solutions, putting plans together with a unified front that says, hey, we're here to do no harm and to do more collective good and see what we can do to make those happen.
Yeah. I'm going to stick with you, Toniann, on the question of, rural providers, safety net providers. I know a lot of the people that are in the Motivo community, they're community mental health providers. They work at community mental health organizations, often seen as the safety net providers of our organization. So think a couple of years down the road when this bill's in full effect, what will it look like then, possibly? Longer wait times, more care and shorter wait times? What do you see?
I think the initial piece is depending upon how all of the provider tax pieces shake out, the reduction of eligible lives on Medicaid. We're also concerned about our dual eligible population, those with disabilities, nursing homes, et cetera. And if you think about the reduction of all of that, part of it will really depend upon how the states then figure out how to do their Medicaid financing. Missouri is one of 3 states that passed Medicaid expansion through a ballot initiative, which adds another layer of complexity to all of that. And so I think the first big piece is going to really be who is going to lose their coverage. What does that look like? And of those people losing coverage, how many are actively seeking care in the behavioral health space, mental health space? How many are not that need to be? And what does that mean for where they receive their care? So right time, right place, right payment, right? Mm-hmm. So community organizations, community mental health centers, they're really going to have to evaluate what are some of their private financing options. Do they have foundations in the area to offset that? How does it affect their slide fee scale program? FQHCs, some are very good in the behavioral health space. Some are not very good in the behavioral health space, and most of them would admit that. We partner with our community mental health center on a lot of activities because we don't have the capacity to provide the best resources for the patient at the time and place. And I think all of us are going to have to step up our game, especially as it relates to uninsured, underinsured individuals. The other big piece will be, we all survived the Medicaid unwinding after COVID. And so we hit this sort of rebound space. Now we're going to be, I guess, winding it back up again and unwinding it again. And so what does that communication look like? What are those strategies around connecting with people when they lose their coverage or if they lose their coverage, and how to re-enroll if that's an opportunity for them?
Yeah, that's helpful. That seems like it introduces a lot more complexity to an already pretty vulnerable population.
Mm-hmm.
I think that's definitely something we're going to have to pay attention to. Anna, want to ask you about, under Biden, there were a lot of rules that were meant to streamline enrollment in Medicaid. That is being delayed now by OBBBA. How do you think that is going to impact startups looking to expand care? Or, you work obviously at the intersection of community mental health and startups. What does that look like from your vantage point?
Yeah, well, sort of like Toniann was saying, I think obviously we want to make sure that individuals understand what their eligibility options are. And that's an opportunity for not just provide, all of us to work together, health plans, providers, governmental organizations, and even startups. There are also tech-enabled organizations, tech-powered organizations that are coming out to support enrollment and communication with individuals whose eligibility may or may not be shifting. And so, maybe there's opportunity, kind of like the way you were saying how Motivo was born out of a moment of change, right? There's opportunities too to make this communication piece of things more scalable, which I think is exciting, right? All of us, I don't know. I mean, I can at least speak for myself. Like, I've certainly been in situations myself when I find my coverage confusing, or I could use support navigating it. And so the better and clearer we can make that communication, the better, of course. But I think, it kind of comes back to what I was saying before, that since we don't know exactly what's going to happen yet, and there's going to be a lot of figuring out of not just things at the federal level, but also how states interpret them, right? And like Toniann was saying, there are implications for expansion states versus non-expansion states, implications based on what the state's, relationship is to Medicaid at the time. And there's a lot of variables. And I come back to, what can we control? We can control thinking about different scenarios and the types of care we would give in those scenarios, and if and when there might be care that we or another organization can't offer anymore, it doesn't make sense to offer anymore, where do we want those folks to go, right? Because we all are responsible collectively. If you consider yourself a safety net provider and part of a safety net, you consider yourself responsible for the result overall. And so for us, for instance, we work a lot with health systems and academic medicine, right? They have services, they have amazing services, robust services, end-to-end services, but they don't do every single thing, or they have certain capacity areas that they might, they might be full. And so we're a partner there, right? We don't do higher levels of care. We have to look for places if a patient is with us and they need something beyond outpatient, where do they go? That's the micro example. This is just the macro version of that. And hopefully will be an opportunity for us to even formalize, expand some of those types of relationships. Thinking about, we can never rely on any one scenario to continue to be the way. Any state could change coverage eligibility, even outside of federal legislation at any time. Any state could change premiums for how a certain specialty plan looks at any time. And that impacts what the benefits are that are available. So I have tried to flip my script and thinking as much as I can to like proactive ideas that seem sustainable, as opposed to like fear that is based in uncertain, which is so understandable. And of course we all have uncertainty is scary. But the building blocks of our philosophy will stay the same.
I think that's really well said around that fear of uncertainty. That's such a larger theme. I think of that just as a therapist, like dealing with ambiguity is very hard for people. We want to really understand, like, tell me exactly what I need to know. And hopefully we can give some nuggets of that today. But I think from what I've heard from just my conversations with you all so far, there's still a lot that's unknown. There's still a lot that we're not sure how it's going to shake out. So if you're feeling a little bit and you're like listening into this and you're like, I'm still not quite understanding and grasping that, I think it's because it's in motion right now. We still don't know exactly how it's going to impact. So we're giving some thoughts and ideas about how it could impact, but there's a lot we still don't know. Stephanie, I'm wondering if I can lob over this question from the chat for you, because I think it's a good one from Adina. She says, she's a CSWA, which I'm going to say is Clinical Social Work Associate, I bet is what that is. Concerned about how this bill will impact her encounters with clients. Will the reimbursement rate be lower for associate providers under OBBBA? Do you know?
Yeah, I saw that question, and I think back to Rachel, what you were saying, and Anna, the rates are really determined by the state. So there's still so much to be determined around federal funding and how the states are supported, but ultimately each state is the one that determines those rates. So unfortunately, it goes back to the unknown. It is not something that is a topic right now. If anything, rates continue to increase to try to meet the needs of workforce development and stability and the services that are being provided and all of those different things. So there will likely always be a difference between an associate type level and an independently licensed and then a physician. There's different scalings for that, but nothing, it is not a top of mind. But again, back to the uncertainty, it's something that each state is going to have to navigate through.
That's good clarity. Thank you for that. I want to get to talking about, workforce and those types of topics as well, but I think we're already doing well on time. So I want to ask this question from Danielle in the chat. What facts do we have currently about how the bill will impact mental health? And, we've already said, right, there's a lot of ambiguity, there's a lot of uncertainty, but what is like one distilled thing that you are like, this is coming, this is happening, and it impacts mental health? Anna, do you want to start?
Well, we know that there is funding allocated towards, or there is a pledge to allocate funding towards rural health initiatives. We also know that there are open requests for comment today from the federal government with regards to coverage for virtual care that anyone can participate in, right? So even if we don't know the facts of what that, like the die may not be cast on something, the facts of focus areas we have in those two places, both commitment towards rural health, commitment towards virtual care, and an exciting opportunity for any of us to share what we think, right? Through those open, and I've seen people, I mean, I've seen the federal government receive thousands and thousands of comments on things that, you know, are important because they're informed by people who do it every day. And so that's something that I like as an idea, and I think is available to any of us, is to say, hey, here's my take on how virtual care impacts my practice, what I think should continue to be covered, et cetera. Because we do know for a fact, and I appreciate that question, right? We do know for a fact that there is openness to hear that feedback. It's not necessarily direct, it's sort of like related to this actual legislation, but happening kind of in parallel.
That's a good fact to hold on to. And I want to get Stephanie and Toniann's on that as well. But here's one question that I have around this. It's not on the agenda, I'm sorry. But like this $50 billion rural transformation thing, it's like if you're just an individual in private practice, how do you know what your state is going to pitch for that? I mean, you said by the end of the year, these proposals have to be put. Can anyone submit a proposal? How does your voice get heard as a rural provider, as an individual clinician, as an associate provider? Do you guys know?
So I'm gonna default on the details to Stephanie and hope that she can give some
She loves that, I can tell.
solid details.
Like,
but
great.
what I will say is I don't know the answer to that question. However, I want to echo what Anna said about comments to regulatory feedback. I cannot tell you how important those sign-on letters are. Know what's happening in your space. Don't be intimidated by, oh, I'm just Toniann. I'm just, some country kid from central Kansas that grew up with hay bales and cattle. So I don't get to say what I think about what is happening at our state and federal level. I want everybody to just kick that to the curb because it's so important that we all speak our ideas and our minds and our values. And we have seen true change in how legislators think about bills, but then also how the bureaucrats do the implementation on the regulatory side. And so just please, however this continues to go, somebody put in the chat, and I just love it. I appreciate the optimism around these challenges. We are in healthcare, we are very good problem solvers. And so let's not lose those conversations, let's not lose the energy around, hey, this is what we're up against, but what are some of those solutions? So please be sure to sign in on those comments. And I'm going to let Stephanie try to answer the right piece.
She loves it.
So the answer is vague, right? Each state is going to differ, and it's going to look a little bit different. But one thing that excites us about the bill is the focus on innovation, supporting SDOH needs, integration of behavioral health and physical health, workforce development. So all of those things are likely incorporated into this opportunity, but definitely worth going back. And to Toniann's point, it doesn't matter who you are, you can advocate and push for some of that funding to see, what you can bring to your area.
A question, advocate to like who? Are you reaching out? Like if I lived in Georgia, would I be contacting the Georgia Department of Behavioral Health and Developmental Disabilities? Or should I be contacting the state Medicaid plan? Who am I talking to advocate for my ideas?
So I think it depends on the idea. So it could be your local representation. Like if this is a localized initiative and something you want to work on, they answer the phone. It works. So you can call them, you can email them. It might be an aide, but they do answer. There are often various events hosted by community supports that are like there's different names for them, but like, go advocate on the Hill. So it'll be a day, and that organization will schedule out for you to meet with your various representatives. And then again, back to each state is different. In Ohio, there's the Ohio Department of Behavioral Health. So that supports all things more regulatory. It supports the boards, supports the community mental health centers. It's a different department from Medicaid. So we adhere to kind of both of their policies, procedures, initiatives, priority areas, and things like that. So again, it goes back to each state is different, but yes, I mean, you can advocate across the board. Usually the departments of behavioral health have advocacy days or have open events for you to come and discuss different things like that. Collective impact is always most powerful. So bringing a group of like-minded individuals together, creating proposals, having very clear and understood outcomes is very helpful and beneficial in these types of scenarios.
That's great. That's good to know. I just put, oh, sorry, go ahead, Anna, go ahead.
Just to add to that, to be a little bit more specific about what I was saying, there's of course, like Stephanie and Toniann were saying, there's your organizations in your state, there's your professional organization that, association, Board of Social Work, Association of Social Workers in your state that represents your, especially if you're a licensed provider, but also the federal government requests comment from anybody all the time, virtually, just on, their websites. And so that's something that, just like Toniann was saying, there's advocacy where you can sign on to letters that organizations that have an interest groups are doing, but there's also just the ability to, I think that's a cool thing about our system is you can say, hey, here's my thought. And they've asked for comment about deregulation. They've asked and ideas. They asked in the past, I've seen a lot of requests for comment on fee schedules, which would impact. I saw a question about telehealth and coverage of telehealth, right? So that's an opportunity as well to leave feedback there through the fee schedule requests for comment.
Yeah. I love too what Stephanie said about the fact that you can call them and that they answer I think that's one of the benefits of behavioral health, oftentimes having its own little like carve out over here of how they deal with it. It's frustrating from the larger healthcare system, obviously, but oftentimes you can get to your people, to the people who are just over behavioral health a little bit easier than if it was like a larger like nursing problem. I'm just going to make a quick note to some of the people like Chanel and Ronald. You've made great comments there in the chat. They're just going to the host and panelists though. So repost that, what you said about NASW and the Department of Mental Health and Primary Care Association, and change it to send it to everybody and not just the host. I want to come back to Toniann and Stephanie around the one fact that Danielle had. What fact do we have about this bill currently? What's one thing you could offer that says this is coming? Stephanie, you want to start?
I have three. So
great.
One goes back to the focus on SDOH needs. So there's, especially around behavioral health services, behavioral services are critical, but if somebody cannot get transportation to the services, if somebody cannot buy food to be on the right, if the basic needs of somebody is not met, anything else that comes after that isn't going to be conducive. So it's really encouraging that there's so much focus around that. The second, and I think we can all agree, is more focus around integration between behavioral health and physical health. They are not standalone. Toniann lives that every day from an FQ perspective, but it's encouraging to see that. The last that is a fact are work requirements. So in Ohio, we're already doing pilots with the Ohio Department of Medicaid around work requirements. How can we be most supportive? How can we ensure, again, those that are in need of Medicaid and needing services have the resources available to meet these new requirements?
Mm-hmm. Great. That's so helpful, Stephanie. Toniann, go ahead.
So, yeah, I feel like, okay, she got my one big answer. I'll also add, we do know that the tax credits for the marketplace, which we haven't talked a lot about marketplace, but those were already scheduled to end. And so those subsidies and tax credits, while there was maybe some hope at one point that they would not end, those are going to be going away. And I don't say that from a doomsday perspective. I say that because it was kind of one of those things that we thought, oh, maybe we'll fight and maybe we'll be able to get that back. I think now we know for sure. with those subsidies and tax credits going away, we are going to need to find solutions for those individuals that are going to fall in that space. And just to kind of give you an idea, my rural statistics are a lot better than globally. However, on average, rural communities that were participating in these premium tax credits, they were anywhere from $1,000 to $2,000 a year in tax credits. And we could probably have a whole nother lively discussion on how healthcare financing works. But those tax credits were actually dollar for dollar back. And so there was ways where they were really unburdening some people from a tax perspective on that. So not only are they going to be losing those tax credits, but they're also not going to be able to have those deductions on their income taxes from a payment standpoint.
Mm-hmm. This is not good news. Some of these facts are not good news.
Yeah.
One of the things that it's already been suggested, thank you, Randy, in the Q&A around, Motivo will consolidate some of your suggestions here and add some additional ones to it for some talking points. The people who are listening to this call, I guarantee are not like legislators who are creating these responses for the funding. They're the ones who are going to be impacted by it, right? So if it's helpful to those of you who are listening, we'll send out here are some talking points that would be helpful when speaking to your legislators, when speaking to your associations about what you can do. A quick question from Jesse here. He said, or he or she, I'm not sure, will telehealth change? Are we going to have to start seeing clients in person? Any mention of that in OBBBA? I haven't heard anything. Please say no.
And I'm going to default to you specifically, but I think it's parallel tracks. And so far, still, from our perspective, positive encouragement around telehealth. But Anna, anything on your end?
Yeah, so there are separate from OBBBA, right? There were telehealth flexibilities put in place specifically with regard to Medicare beneficiaries that have been extended multiple times, but this predates this particular legislation, and there are current, as far as I understand, it's part of the request for comment that I was talking about, right? When we look at the fee schedule going forward for Medicare, there's an ongoing discussion about this has been something that has been a temporary flexibility that's been extended, right? But as Rachel kicked things off at the beginning, it wasn't something that was pervasively available before COVID. And so there's some sort of action needed to be taken to make that type of thing permanent. However, coming back to what Stephanie said, I haven't heard anything at this for Medicaid beneficiaries, right? You're talking about the state and them determining what they want to cover. And the plans that I work with, people like Stephanie all across the country continue to have lots of commitment to, in my conversations, serving people in rural areas where telehealth is a critical component of that. And this is I just was having a conversation with a health plan yesterday where they were saying all of our behavioral health providers are concentrated near the capital, and rural access is telehealth access in that sense, right? They go hand in hand. And so those commitments, I am not seeing change at the state level. When we start to talk about employer coverage, right, through private insurance companies, that's really that's not, I think that continues to be a discussion that is kind of happening outside of a little bit parallel to this, not completely parallel, but a little bit parallel. So like Stephanie was saying, I am biased as I really believe in it and it's what we do, but I also feel like the energy around the importance of what telehealth makes possible for people who wouldn't otherwise have access is still there, with the important caveat, as Stephanie mentioned, and I think someone in the chat mentioned this as well, that there are infrastructure needs to make telehealth available to somebody, right? And it's not magically available. You have to have the device that will allow you to engage. You have to have the right sort of connectivity that will allow you to engage. And this is somewhere where I'm hopeful that continued funding for rural health will also make some of that infrastructure stronger, because the fact that the service is covered or exists doesn't necessarily mean every single person can access it. And we need to continue to make that coverage broader.
Yeah, on the coverage issue, thank you for that, Anna. This question from Tracy I really like as well. She said, when you say there will be a reduction in individuals who receive Medicaid, why is that? Is it that the income baseline is changing? I think I read somewhere that there's going to be more frequent eligibility checks, that you're going to have to re-enroll more often. Who feels best at able to take that? What is it? What does
Probably
that mean?
the Medicaid person. Yes, so the re-enrollment will be more frequent and there will be more documentation requirements. So that in and of itself might add some barriers and might result in identifying somebody is not qualified anymore for Medicaid. The other piece will be around the work requirements, the education requirements, ensuring people are active, in their lives and their communities and things like that. The last piece is around the Medicaid expansion. So that is the potential for the percentage of income to change, so less individuals are qualified to be part of that program.
Mhm. That could be one of our suggestions in the document. I'm thinking, Deanna, thank you for your comment here. I think, she says losing coverage is rarely a poverty reducer for the working poor. What solutions do you recommend that we advocate for that we have not already? Anything you can think of?
So that's a huge one. There, in Ohio, a lot of organizations, including Caresource, came together and created a advocacy group. And that is really, they honed in on the Medicaid expansion lives, especially the behavioral health population. Because again, it's a big part of that population. And without service or without the access to services, then increase of the ED and increase of comorbidities and decrease of annual care, all of those things are going to occur. It's going to be a bit of a domino effect. So there's been great conversation in Ohio, even in DC. Folks are hearing that, they understand, and there's a lot of support on how we can come together to find some innovative solutions.
Right, right. Let's turn our attention a little bit to workforce, and thank you for all these great questions. Keep them coming. I'm prioritizing your questions over my questions. So if you have other things you want to ask about, please go ahead. What do you think that this means for the future of the behavioral health workforce? Some of you might have already seen Motivo's white paper on this, that 57% of the people who get a master's degree in counseling or social work don't make it through the licensure process, right? We're losing over half of the available supply of therapists in this licensure pipeline. A couple of reasons for that, right? Supervision is often difficult to find and hard to access. Some people have to pay out of pocket for it. Pay in rural community mental health centers is often quite low. Pay across the board for associate level clinicians is quite low. We also use our greenest clinicians to serve the most vulnerable populations. My first job out of grad school was working with chronically homeless adults in LA, knowing nothing, absolutely nothing about what I was doing. So I say all that to say this workforce pipeline is already a difficult thing for us. How is OBBBA going to make that easier or harder? Anna, let's start with you.
Yeah, it's interesting. I think we all follow, of course, Motivo, you're the experts on this, but it's sort of there's thematic things that are happening that are not necessarily directly OBBBA, but kind of happening again in parallel. So we should be close to the professional counselor compact going live soon, right? So that is, could be enormously impactful to workforce, have enormous workforce implications, right? Thinking about, okay, I think we're at 39 states and DC have signed on, done legislation so far to participate in the professional counselor compact. That is so big, right? As a concept, because it makes it permissible for somebody to practice in one of those other states through the sort of framework of the compact. To me, though, where I'm really watching and workforce permissibility is just the first step, right? And then it's about funding. And so that's where I come back to there is, and that's a good point, Fred. I think I'm specifically talking about the counselor compact, and I know less about the social worker compact, although I think that there's also some stuff happening there. But I think it's a very exciting thought to think about what could a compact mean. But I also think that it's going to come back to, okay, if things like compacts may bring, again, more access to provide services for folks in rural areas, okay, so how are we going to reimburse services for people who are able to practice through the compact, right? Because it doesn't give you a license. It's a different like regulatory framework. We need to think through how that actually works in process, in reality. And I think it's fantastic work, and a lot of people have done hard work to make this possible, but I am continuing to keep an eye on and hoping to be in dialogue with managed care and states around what it means to reimburse for that, because we can't, it doesn't really change the access problem if what we're allowing is for people to see self-pay. I mean, it's great, wonderful to be able to see a self-pay client if they move to another state, right? But it doesn't change the public health discussion in the way that I think we all envision that it could. So again, hoping that through the looking at some of these things, both workforce as well as different types of investments through the lens of rural health access is a place that I am hopeful for momentum. And again, more conversations with Toniann needed.
Yeah. I want to switch to Stephanie and Toniann on the workforce question, but let me do a couple things from the chat that's coming up. And Dr. Carla, she's our Chief Clinical Officer. I think she's on the call, and I'm wondering, Carla, oh, somebody just put the counseling compact in here. That's great. There is a compact for all of them. Psychologists have one, social workers, counselors, MFTs. We'll put the link to all of them. I think the one big distinction that I want to make too is that those don't apply to associate level clinicians, right? You have to be fully licensed. I think that's one of the problems with a lot of the funding that exists out there. I received the National Health Service Corps loan repayment program, where I got $60,000 of my student loans paid off in exchange for working for 2 years in a high need area. But I had to be fully licensed before I could get it. To me, that is like one of the biggest opportunities to change things, is like, we need to help the pipeline of people who we are losing over half of them before they even get started. That's a big one. But I do agree, Anna, that it is going to help for fully licensed providers to be able to provide services across state lines. Stephanie, you were going to say something about workforce. Go right ahead.
I was going to kind of piggyback off of these conversations. It was really eye-opening during COVID when there were so many temporary reciprocity opportunities, like in Indiana. I mean, within 30 minutes, you could get reciprocity into Indiana and be able to treat. And so I think it was a really good lesson learned that it's such a critical thing. And that started to wind back. I was working in a provider that was doing virtual care. It was really challenging for the folks who had the temporary license to have to quickly then get the actual reciprocity and go through the process, and the barriers to that, the cost to that. And sometimes you can't even do it because your degree doesn't quite match up with what their degree requirements are. So again, back to advocacy, collective impact, bring folks together who are passionate about this topic, talk to your states, different things like that. But for workforce, Caresource is super excited about workforce development and all the innovative opportunities that are out there. And this bill will continue to allow for that. So we kicked off an internal workforce development committee about 6 months ago. We have a strategy and lots of different programming and opportunities really focused on bringing folks in to the healthcare industry and then keeping them in. I'm sure we can all relate. This is not an easy industry for many of the reasons we've said today. And so we want to figure out, and working with Rachel and her team, how can we best support folks in the field and keep them there. So super excited about that and what's to come there.
Yeah, I will say, just, this is something that's not widely known, and I kind of like for all the people on the call to know about it, that because I think it's oftentimes, especially from the clinician perspective, we can say we need our health plans to do more, we need them to do more, but so many health plans have partnered with Motivo already to just straight out fund clinical supervision for rural and underserved areas. They send us money when we partner with local community providers in a number of states to supplement the cost, sometimes pay it fully, from the perspective of the payer is the one who's footing the bill for that. And so it's a good opportunity, you know, to lean on our health plans and say, can you help us serve this more vulnerable population? It oftentimes, I think, from our perspective, at least for mine, can be like, what are they doing over there? They're doing something. They're often doing something. Toniann, what would you say about workforce?
So this is my shameless plug for area health education centers, way underutilized in this space, but we actually host our AHEC program. And they do so much work around education, pipeline, underserved areas. They actually sit down and help you look at loan repayment options. They help you find supervisors. They're a true unsung hero in the workforce innovation space in rural communities. And they are, I mean, their line item is at threat in the next few years. And so definitely utilize them as a resource. Find out who your AHEC director is. Find out how you can work together, because I know in our space, we're already an underserved MUA, MUP. Medically underserved areas are also going to change some, and there's a lot of questions around that. And I think that recruiting providers to rural communities is a major challenge. Recruiting a behavioral health provider into a rural community is even more difficult. So any way we can invest in these associate type programs through the education and training processes is always going to be helpful. I totally agree. I hate that a lot of those programs, you have to be licensed before you can even apply for them. I do look for continued dialogue to hopefully help modify that more through different state associations over the next few years. So again, put on your advocacy hat and reach out to people, and most definitely try to find ways that you can find that financial support, just like Rachel did through the payers. That's a great idea.
And I think it's important to also, again, research your state. There are so many programs that our state has that they say, hey, we need to get this out there. Folks they don't know about it, or they aren't using it. We want to get these dollars out. And that is tuition reimbursement. That is free support to get your license. That is helping with SDOH needs as the employee. There are so many state resources that go untapped. So definitely look around.
Yeah, great. Thank you for that. And for those asking if the recording will be sent out, yes, it absolutely was. I will. I love Danielle, your comment here, I think is so poignant. Poignant, I never use that word. I'm so impressed. I just use such a big word, poignant. She said, doesn't seem like the compact will have a big impact on the people negatively impacted by OBBBA Medicaid recipients. And I agree with that. You know, when we talk about, you know, the compact and licensed providers and all of that sort of stuff, our community mental health centers are staffed by associate level clinicians. And it sounds like this is just, OBBBA makes it harder, makes it harder to serve the population that comes to them. Is that true? Is that accurate? That it's going to make it harder to serve Medicaid recipients? And I remember what Toniann said earlier in the call, that, you know, community mental health centers might have to rely more on outside funding and fundraising. I can't think of anything more difficult for them. They're already so resource strapped, and they need to now do galas in order to supplement their funding. Can you give us some hope there? Is that the reality of what's going to happen for these community providers, or what can we advocate for to help them, I guess, is my question.
It goes back to the unknown. This is like a cliche thing to say, but I would encourage folks to take a breath, ensure that you are educated on the bill. None of us are experts on this. There are amazing organizations who are, or lobbyists, so find that organization that can really help you understand the impact to your organization, and then start to build your plan. What does that look like? We're seeing a lot of, again, appropriate reactions from community mental health centers, but encouraging them to breathe and, understand really what the impact is. There's so much unknown of how many are folks going to lose Medicaid coverage? Are they going to push out the work requirements? Like so many different things still on the table. So just make sure you have the support in your corner and those that are the experts in this space, and then make that plan.
Okay. And again, we're going to be sending out a list of these are the possible things that you can do based on this call and our own knowledge to everyone afterwards, as well as the recording. We just have the last 5 minutes. And I wonder if maybe like the last question I could ask is just, what have I not asked about that you didn't get to say and that you think that is important for everyone to know? Toniann, let's start with you.
So I would just say, keep asking questions, keep engaging in these types of conversations, keep up to date as best you can with what is happening at the state and federal level, but don't let it consume you. Don't let it, certainly don't let it disrupt you as much as you can. I know that it feels stressful, and I know that it feels, we use the word unknown a lot today. But I also have great expectations for people that are advocating and having conversations and pushing conversations, that the greater good does prevail often. And so I would just encourage everybody to not lose sight of that. Try to find ways to be parts of the solution, and don't be afraid or intimidated to share your good thoughts. I think one piece of advice is, if you are in a position to have conversations with your payers, a lot of them have community liaison type of individuals. Don't hesitate to take them to coffee, let them take you to coffee. Just pick their brain. Hey, what are you hearing? What are ways that you can help support our organization or my private practice or my institution? Share those frustrations, those ideas, those concerns, and let them be part of that solution as well.
Great. Thank you, Toniann. Anna, over to you.
Well, first, I would be remiss. It sounds like we have a lot of folks in attendance who this might be relevant to, and I would be remiss if I didn't just say and share clearly that at Brave Health, we do hire associate therapists and we offer supervision. So just.
And you're in what, 13 states? Is that right?
What, we're in 15.
15 states.
We don't have, I don't know if we may not have associate therapists on staff in some of our newer markets, but in the majority we do. And it's a cornerstone key part of what we do, and partnering with Motivo has been important, critical to us in this as well. So just wanted to put that out there. And, I also wanted to just invite, if there's anybody who is thinking through at an organizational level in any region, I am so looking for these conversations. I want to I want to have as many as I can about how can we support each other. So if you are someone who's thinking through, what do we do as an organization? And we're a rural health center, we're a CMHC, we're a community health provider, we're a nonprofit. I was looking at the RSVP list, lots of fantastic nonprofits. I was looking at a bunch of great organizations in Georgia where we're expanding. We want to talk to you. We want to hear from you. And please don't hesitate to reach out.
Love that. Anna, how can they reach at you? Can you put it in the chat for everyone, or where?
Yeah, I'll put my info. I'll put our website in the chat.
And my understanding, correct me if I'm wrong here, Anna, but Brave partners with community mental health organizations and does virtual care. Is that correct?
We do virtual care, but like I was saying, so we do virtual care and we directly provide care. We have people who work for us directly, and some of them are independently licensed and some of them are under supervision. But we also work with community organizations in the sense that we don't do everything, right? We support each other. And so like I was saying before, as we think about what that could look like in the future, we want to learn and hear feedback. And so that's why I'm welcoming that conversation as well.
Love that. Thank you for that. And Stephanie, your final thoughts on what did you wish I asked about that I didn't?
Yeah, I think just to summarize what has been said is there's no silly idea. I mean, we have partnered with peer support organization to do an internship program to bring folks into the field, and providing vehicles to rural community mental health centers to provide transportation for the employees to get them to work. So there are no silly ideas. This is the time to innovate. Reach out to your plans. They want to work together. Billing is really a very small piece of everything that Medicaid plans do. So I'm always eager to get involved.
Love that. Fred put such like a great final thought here around democracies have historically faced threats and crises, but have often recovered. I know I read this like years ago that older individuals, elderly individuals are the ones who get less like anxious about changes like this. And it's simply because they've ridden the wave so many times of this rollback, this expansion. Now this is happening. Now this is happening. It's nothing that we can't, you know, get in there and tackle together. And that is not to, you know, kind of downplay the impact that this is going to have on many, many people, right? It is, but our ability to kind of share our voice and advocate for it, I think is something that we can all continue to do. So we'll send out a one-pager of how you can get more involved, just some of our tips on it. We'll send, you know, a link to Brave as well. Reach out to us, you know, if we can be of any help from the Motivo side, and we'll send out the reporting as well. Someone asked if we're going to have another discussion like this. We are going to have a discussion in a couple of weeks that I'm happy to send to this list that we've sent it out to if you guys want it, but it's about like, you know, licensure, barriers, the barriers towards licensure for people. You know, New York has just rolled out a new set of requirements around diagnostic privileges that is wreaking havoc among licensed providers in the state. So it's good for us to just share as much information we know there and see if we can be of help. So we'll make sure that this list gets out of as well. But Toniann, Stephanie, Anna, thank you guys so much for bringing some more clarity to us. Yes, Anna put the website in the chat. We'll follow
I
up.
think could figure out how to send it to hosts and panelists. Would somebody from Motivo mind just dropping it in for everybody?
Absolutely. Yes.
I don't know what I'm missing.
It's Be Brave, bebravehealth.com.
Oh,
Be Brave Health. And then Anna at bebravehealth.com. Thank you all for
right,
being
thank you
here.
so
Wonderful to
much.
see you all.
Have a good day.
Thank you.